Hello everyone, this is Dr. Jiang. Now let's review acute leukemias. Here are the objectives. Acute lymphoblastic leukemia, or ALL, is a children's disease. 25% of childhood cancer and 75% of childhood leukemia are ALL. So this is a very important disease among children. 80% can be cured, and this is quite an achievement in medical history. It is rarely seen in adults, but once adults have it, the outlook is much worse. According to WHO, most acute leukemias have at least 20% blasts in the bone marrow. ALL can be classified into two groups based on WHO classification: B lymphoblastic leukemia or lymphoma and T lymphoblastic leukemia or lymphoma. The B cell one can be further classified into 7 subtypes based on cytogenic abnormalities as shown in the table here. Each subtype has its unique clinical and prognosis features. The key feature of peripheral blood field is lymphoblasts. They can be small, which is more common, or larger, as shown in the image here. Those lymphoblasts can be confused with the blasts of acute myeloid leukemia, so immunophenotyping is a more reliable way to confirm the origin of the cell. All ALL have the following 3 markers, as both B and T cell are derived from lymphoid progenitors. They are CD34, terminal deoxynucleotidiotransferase, HLA-DR. ALL can be classified into 4 types by immunophenotyping. There are early B-ALL, including progenitor B, pro-B, pre-B, having CD19, CD78, CD22, nuclear terminal deoxynucleotidiotransferase, or TDT, expressed. Intermediate common ALL having CD10 expressed. Precursor B, pre-B ALL having cytoplasmic mu, and T ALL, which is seen in teenaged males with mediastinal mass, has increased peripheral blast counts, meningeal involvement, and infiltration of extramedullary. They have the common T-cell markers such as CD2, 4, 5, and 8. Prognosis is worse than B-ALL, with relapse occurring sooner, especially central nervous system relapse is more common. Prognosis depends on genetic abnormalities. For example, chromosome translocations are the most strongest predictor of adverse treatment outcomes. When the diagnosis is made, children is usually doing better than infants and teens. How many lymphoblasts at the time of diagnosis and immunophenotype. In B-ALL, genetics correlates well with treatment outcomes. For example, the first one from this table, the B lymphoblastic leukemia lymphoma with translocation between chromosome 9 and 22 and has a mutation of BCR-ABL1 has the worst prognosis. The second one on the list is seen in very young infants and has a poor prognosis, while the one has ETV6, RUNX1 translocation has a very favorable prognosis. Clinically, the patients usually have anemia that leads to fatigue, neutropenia causing infection and fever, and thrombocytopenia causing mucocutaneous bleeding. Lymphadenopathy or enlargement of the lymph nodes often present. Enlargement of the spleen and the liver may be seen. Bone pain may be present due to the infiltration of leukemic cells into the bone covering. Infiltration of malignant cells into meninges, testes, and ovaries often happens. Leukocytosis are seen in half of the patients. Many patients don't have circulating lymphoblasts. Patients are grouped into low, standard, and high-risk groups to be treated differently. For example, children between age 1 to 10 with WBC count less than 50 billion per liter, no extramedullary disease, and respond to initial therapy quickly are considered a low-risk group. High-risk group include adults and infants younger than 1 year old has extramedullary spread, poor response to initial therapy. There are 3 phases of treatment: remission, induction, consolidation, and continuation therapy to get rid of the residual disease. Central nervous system therapy is often included. The chemo drugs are administered into the CNS system via cerebrospinal fluid. Methotrexate is a commonly used drug to treat ALL. It causes megaloblastosis because it is a folate antagonist. Acute myeloid leukemia, or AML, mainly affects children of less than 1 year old, and it is the most common leukemia in adults. It has increased white blood cell count with myeloblasts in peripheral blood film. Like ALL, patients have signs and symptoms of anemia, bleeding due to thrombocytopenia, infection, and fever due to neutropenia. Unlike ALL, patients often don't have bone pain or enlargement of lymph nodes. Lab tests can be consistent with tumor lysis syndrome evidenced by hyperkalemia, hyperphosphatemia, hyperuricemia, hyperuricosuriia, hypocalcemia. The 2008 WHO classification classified all ALL into 7 groups. Each group can have subgroups. Let's be familiar with 6 of them. The group AML with recurrent genetic abnormalities. Know the key features of the subgroup with these 3 translocations. For example, the AML with translocation within chromosome 16 have eosinophils with dysplastic changes seen in bone marrow. Increased eosinophils can be seen in peripheral blood as shown in the image here. The one that has translocation between chromosome 15 and 17 often develop a DIC. The AML with translocation between chromosome 9 and 11 is usually seen in children. They have increased monoblasts and monocytes as shown in the image on the top left in next slide. Gingiva and skin are involved.
Cytochemistry is still useful in some labs. Let's know several most important ones. They are useful when classifying acute leukemia using the FAB system. Myeloperoxidase, or MPO, is only found in granules of myeloid cells, but never in lymphoid cells. Therefore, myeloperoxidase staining can differentiate myeloid from lymphoid blasts. Non-specific esterase, or NSE, is found in large amounts in monocytic cells. Therefore, non-specific esterase staining can be used to identify monocytes. PAS, or periodic acid shift stain, stains glycogen and related mucopolysaccharides. It shows granular pattern with negative background in lymphoblastic leukemia. It stains positive in the erythroid population in erythroblastic leukemias. Tartrate-resistant acid phosphatase TRAP stain is diagnostic for hairy cell leukemia. The cells that demonstrate a positive reaction with the acid phosphatase stain after treatment with tartrate. That's why it is called tartrate-resistant acid phosphatase stain. Sudan black B stain can be used to distinguish between acute lymphoblastic leukemia, in which the cells stain positive, and acute myeloblastic leukemia, in which the cells stain negative. This table shows the FAB classification of acute myeloid leukemia. There are 7 types from M1 to M7. M1 is AML without maturation. Most cells are type 1 and type 2 blasts. Myeloperoxidase or MPO stem positive. M2 is AML with minimal maturation. Most cells are type 2 blasts with oral rods. MPO stem positive. Notice translocation between chromosome 8 and 21 are associated with M2 AML. M3 is acute promyelocytic leukemia. The predominant cells are abnormal promyelocytes with oral rods. Translocation between chromosome 15 and 17 are associated with this type. Patients often develop DIC. M4 is acute myelomonocytic leukemia. There are lots of monocytes. That's why non-specific esterase stain is positive. Inversion of chromosome 16 is seen in this type. Patients often have gum infiltration. M5 is acute monocytic leukemia. Most cells are monoblasts, promonocytes, and monocytes. Again, non-specific esterase stain is positive. Patients often have gum infiltration. M6 is acute erythroblastic leukemia. Over half of cells are abnormal nucleated red cells. NSE and PAS stain positive. M7 is acute megakaryocytic leukemia. The predominant cells are atypical megalokaryocytes. There's a last type, we call it M0, which is myeloid leukemia with minimal differentiation.
The image on the top right is from acute monoblastic leukemia with promonocytes. The image on the bottom left is an image from acute erythroid leukemia. Notice the erythroid precursors showing dysplastic features. Pronormoblasts and basophilic normoblasts are affected. The image on the bottom right is from acute megakaryocytic leukemia. All these 4 cells are blasts. They look quite different, but all express CD61. That's the end of this review. Thank you very much for your attention.